I had a difficult time at first confirming a site for my fieldwork than I anticipated. I called a couple of people at the health department, some clinics known for serving the uninsured and immigrants, and one of the main hospitals in the area without success. After making many calls and leaving several messages, I was successful in making contact with a Spanish interpreter fieldwork at Bethesda Health Center, a free and affordable clinic that serves uninsured and underserved immigrant population living in Mecklenburg County. The clinic turned out to be a great site because of the population it served was very appropriate for this class and for the presentation. I followed the Spanish interpreter during my visits with the clinic. My goal was to get a better recognition and understanding of barriers and challenges to accessing health care from an immigrant patient standpoint. On my first visit, I was introduced to the staff, which consists of a couple of volunteer doctors and nurses, Spanish interpreters, the center director and administrative personnel. There was a 585% rise in the Hispanic population in North Carolina between 1990 and 2004. And 54% of Hispanic adults in North Carolina are uninsured, compared to 11% for non-Hispanic whites and 22% for African Americans. This has put a major strain on the healthcare community in North Carolina. In 2005, the Mecklenburg County Health Department provided care to 17,500 Hispanic patients. This is 26% of their total patient population. This is up from 17% of the health department patients seen in 2000. In a 2013 community health assessment by Mecklenburg County, county residents rank access to care as the third leading public health concern. Bethesda Health Center is one of many free and low-cost clinics in Mecklenburg County that attempts to address the issues with increasing demand for quality health care in uninsured and underinsured immigrants. The clinic was founded by Camino del Rey Baptist Church. The clinic population is about 98% Spanish-speaking men and women between ages 16 to 65. The patients come mainly through word of mouth. Over 97% of the individuals served do not have a regular doctor. Individuals must meet a financial screening criteria, and the fee for the screening is $10. Qualification screening and interviews are done on Thursdays at the clinic. The clinic sees patients by appointments only on Tuesdays and Wednesdays. The clinic provides primary care service, exercise and educational classes, and a little food pantry. Volunteer providers, which can be from 1 to 2 providers, see about 25 to 40 patients per night. The top 3 chronic conditions managed at the clinics are cardiovascular disease, hypertension, and diabetes. I did observe some challenges with the clinic, including limitations in hours and health services because of limited funding. The clinic does not provide emergency care. It does not provide pharmaceuticals or medication services on site, but providers can give prescription, and the clinic cannot meet every medical need. There is a disconnect of care seen in that although patients can return to the clinic by appointments as needed, but medical complications could go unnoticed, and there's a risk that things could fall through the cracks because of the limited time with the clinic providers or the irregularity of the visits. A regular doctor would have access to a patient's comprehensive medical records and history, including immunizations, allergies, past surgeries, but the clinic may not have any of this information. Clinic providers would have a harder time picking up on symptoms if anything major is brewing because of lack of relationship and contact with the patient. There is a growing demand for services which puts pressure on the clinic and the few volunteer staff. A large number of the immigrants they serve poses cultural sensitivity and challenges. There is a lack of access to specialists in the clinic, including orthopedists, dentists, ophthalmologists, and so forth. The number of volunteer providers is declining even as the need for services increase, and the clinic is in need of more volunteers. Application to future practice with these issues are: patients will be referred to primary care providers and specialists for more extensive evaluation and treatment based on availability and based on referrals from these clinics. It is important for the nurse practitioner to understand the medical and socioeconomic concerns these patients present with. A practitioner with a strong communication skills and understanding of cultural sensitivity can positively impact the effectiveness of care that is being delivered to these immigrant patients. According to a 2013 evidence-based article by Ms. Johnny Noog, a nurse practitioner in Northeast Oklahoma, most community health centers have similar experiences in regards to conditions they treat and challenges they face. In a 2004 national survey of 439 community health clinic directors, 30% said that uninsured patients are rarely or never able to obtain access to specialized referral services, and 50% said the same for access to high-tech services such as labs and imaging studies. As such, when uninsured immigrants need specialized services, they rely heavily on hospital emergency departments. In 2009, the United States spent an estimated $2.5 trillion on healthcare, which is more than 3 times what was spent in 1990. And there were over 50 million medically uninsured people in the United States in 2009. The top 3 chronic conditions diagnosed at free clinics are cardiovascular disease, hypertension, and diabetes. And these chronic conditions can further complicate minor illnesses that can be treated in these free clinics. Despite the generosity of few volunteers at these clinics, only a fraction of the uninsured are served by these clinics, indicating that services need to be expanded. A 2012 observational study in Virginia found that nationally, patients at free clinics are 3 times more likely to seek care for chronic conditions compared to insured patients who go to physician offices. The study recommends expanding primary care providers by providing financial incentives through debt relief programs for advanced nurse practitioners and medical students specializing in primary care, expanding residency programs in primary care, and raising the salaries and reimbursement rates for primary care professionals. Another recommendation is for the medical community as a whole to reevaluate the critical role of primary care and create a culture that recognizes the values of primary care professionals. Free clinics can make a difference to immigrants by providing much needed access to medical care. They decrease the financial burdens on area hospitals and can enhance public opinion of primary care providers, including advanced practice registered nurses. Free health clinics exist to ensure access to health care by providing a safety net for underserved populations and immigrants. Ultimately, this decreases the health disparities among people of different socioeconomic and cultural background.